Good morning, everyone. Good morning, students. Welcome to the Second Sunday Forum for April. I'm Tyler Taylor, a longtime member of the church. I'm also a retired family physician, and mental health issues are a big part of what most family doctors do during any given week. So this is a topic that's dear to my heart. The title is Beyond Depression, Understanding Serious Mental Illness and Supporting Individuals and Families. Often we have one speaker. Today we're really fortunate to have two dynamo speakers from the National Alliance on Mental Illness, or NAMI. They'll talk for roughly 30 minutes, and then we'll have questions and comments after that. And I'll roam around with a microphone. We'd like to be able for everybody to hear the questions and comments, and also to have them recorded, since this is being recorded and will go up on our website in the next day or two. First speaker is Dr. Jonathan Gordon, who during his medical career was Chief of Family Medicine for Kaiser Permanente in Colorado. In that role, he became very involved in delivery care models for mental illness. That translated into him doing these four things that I think are pretty remarkable. Serving on Kaiser's group establishing national guidelines for depression, helping implement screening tools for mental illness during visits to primary care, helping place behavioral health specialists in every primary care clinic, which would just be amazing if that was the rule nationally, working with their behavioral health department to implement a zero suicide screening process. Following his retirement, Dr. Gordon joined the board of directors of Mental Health Colorado and worked with legislators on specific bills in Colorado to support and improve the care model for mental health. Additionally, he was also on the board for a large community mental health center in Lakewood, Colorado. Since moving to Santa Fe with his wife Julia 4 years ago, Julia's here today with us, he has become president of the board of directors of NAMI in Santa Fe and served on their county behavioral health leadership council. He's presently leading a collaborative effort to build a regional mental health interdisciplinary teaching hospital in Santa Fe. Regional mental health interdisciplinary teaching hospital in Santa Fe. That would be a really big deal. When he sent me his bio info, his final comment was, "Some days I'm aging graciously and some days I'm just aging." So our second speaker will be Betty Cisneros-Shover. Betty serves as the executive director for NAMI in Santa Fe, and after several years as president of its board of directors. Earlier in her career, she worked as a software engineer, so she brought a background in technical problem solving to her current work in community mental health advocacy. And that software engineering part is kind of close to the hearts of people here, right? Additionally, she is a NAMI trained facilitator for multiple family education and support programs. Additionally, she serves on the NAMI New Mexico Legislative Committee, which means she attends legislative hearings and testifies in support of behavioral health legislation. Her work in mental health advocacy has been recognized by both Santa Fe's 10 Who Made a Difference honor and the state of New Mexico's Behavioral Health Star Award. Betty first became involved with NAMI more than 20 years ago when a family member was diagnosed with bipolar disorder, and she turned to NAMI for guidance and support. Since then, she has been a dedicated advocate and caregiver, working to support individuals and families while building greater understanding, compassion, and hope within the community. Betty's final comment was that she hopes to see the day when mental illnesses are fully recognized and understood as biological brain disorders, and when stigma no longer stands in the way of compassion, treatment, and recovery. Please welcome these two very experienced and dedicated speakers.
Tyler, thank you for that very gracious welcome, and I will be obviously accepting the Nobel Prize right afterwards for all the work that I've done. Betty and I are very honored to be a part of the forum's team, and gracious that you invited us to talk about something that's near and dear to my heart. Betty and I have been working together for NAMI Santa Fe now for about 2.5 years, maybe a little bit longer. And Betty's going to be doing part 2. I'm going to be doing the first part, and I'm going to be talking about stigma and serious mental illness, and lead into a little bit of the work of NAMI Santa Fe. How many of you know about NAMI? Well, thank you. I'm done with part 1. So the National Alliance on Mental Illness was actually founded about over 45 years ago. 2 moms were sitting together and talking about their sons who had schizophrenia. And what they found out is that there were so limited resources on how to get care for their loved ones and their families, and they were sharing the same experiences. And what they found out was it was more powerful to share the stories, to work together as a team, and to find out how to resolve these issues. That was really baffling to a lot of people of why that mental health and mental health care had become such an orphan child in healthcare these days. And that was in 1979. And if you move ahead 45 years, I worry how much has changed, but I'm glad some things are getting better. So it's working together, working to find out what are the missing pieces. But you'll find out through our discussion today how we're working to actually improve this whole environment. NAMI itself right now has about 600 affiliates in 50 states. And the dedication of the National Alliance on Mental Illness is based on education, support, and understanding of mental illness. And actually, another piece is to give hope, and also to erase the stigma for mental health. And that's a huge battle that we find that's going on constantly. As a family doc, I got into behavioral health and understanding it very early on in my career. In the 1980s, 2 medications came on board. One was Wellbutrin and one was Prozac. And what happened was that both medicines were being pushed, is a nice way to say it. And I started using Prozac a lot more, just kind of experimenting to see how this medicine would work. Granted, there were other medications available, but those had significant side effects. So one of my early patients was a nurse and came in with classic symptoms of depression. I put her on the medication, and over a month or 2, I noticed that she was having a side effect. And that side effect was I had not experienced, and started doing medical workup to find out what was causing this metabolic problem. I finally, after about a couple of months, I turned to her and I said, you know, I think it's the side effects of this medicine called Prozac. I said, would you like me to stop the medication? And she looked at me and said, this is the first time I felt like myself. And that hit me harder than anything. I went, wow, a medication that's transformative, that really helps people to such an extreme degree or a wonderful degree, I feel like myself. And that was just a real eye-opener that can happen. That doesn't happen with everybody, I have to say. And over the next 40 years of practicing, I realized that it wasn't exactly all smooth sailing with medications. As Dr. Taylor could probably agree with me, a lot of trials with medications in people, but that's part of it. The other reason I got very involved was my wife and I, Julia, who's here with me today, we both have lived experience with our daughter, and that was a huge difference in changing my eyes and feelings about mental health. You know, as a doctor, I'm well trained in the science of medicine, but what you learn about mental health is also the heart of medicine that you have to figure out. You have to really understand that it's more about the compassion and understanding and how you communicate. And it's less about, you know, carbon bondings and organic chemistry and physiological changes and understanding the chemistry in the brain. And that's what I had to understand, is that balance between medically trained and humanly trained. And that was very important for mental health. How many of you, and this is, you have to raise your hand on this one, I got 2 raise your hand questions. How many of you have a loved one or a family member who has experienced or lives now with mental illness? All right, I can leave early again. This is great. Okay, part 2 is the challenge question. The challenge question is, how many of you are comfortable talking to that individual about their mental illness? Oh, this is a great group. That's great. Thank you, all of you. This is going to help me. A number of years ago, this is a little story, and oh, that's right. I get caught up in my stories. I apologize. Let me see where I'm at. A number of years ago, sitting down with my wife, Julia, with our friends, John and Joni. I won't use their last names so I can protect them. John is a colleague of mine at Kaiser. He was a geriatrician, very well trained, very smart. His wife was a retired internist. And we were talking about mental health and having a very open conversation about how my wife and I were experiencing what our daughter was going through with her mental health issues. And in the middle of the conversation, Joni, who is a trained internist, retired, turned to John and said, "We don't have anybody in our family with mental illness, do we, John?" And right. And I basically really didn't say anything. I had to be quiet because about a month earlier, one of their daughters approached me asking for help with her mental illness. She was afraid to talk to her own parents, who are both doctors, about mental illness. I thought, okay, fine, I can work with that. I referred her to a colleague of mine who was the chief of psychiatry at Kaiser, and who called me up, thanked me for the referral, and said, "By the way, I'm also taking care of her sister." I went, wow. All right, so that's a story. That's how I introduced the concept of stigma, is that at all levels, stigma exists. And it's something that we have to deal with. Paranoid schizophrenia is no longer DSM. It's not a term we use anymore, but this is just an example of what stigma has developed. Stigma comes from the word, is a Greek word, and it means shame, devaluation, limiting human value of who you are. And we'll go back in time a long time ago, because in many, many years ago, those with mental illness were actually they were made slaves. They made them slaves. Or they were put in their jail system. Fascinating that 30 to 40% of the inmates in our jail systems throughout the country have serious mental illness. Now, We can discuss about if that's progress or not. I have serious doubts about, where we've gone. And as I give this talk a little bit further, take a deeper dive, you'll see what I'm talking about. Those, at one point, it was defined, stigma was defined, or mental illness was defined as God's punishment. And they were treated with fire so they could be purified. Okay, so things got better. And in the 17th century, they put people with mental illness into asylums. Now, all of us have seen these television shows or movies of people living in asylums with mental illness, kind of people walking around like zombies. And it's really sad. It's really scary. Well, things got worse. In World War II, the Nazis killed or castrated over 300,000 people with mental illness or physical disabilities. They were considered a burden to the state. In the United States, the peak numbers of people in psych hospitals, state psych hospitals, in the 50s reached 500,000. Over 500,000 were in psych hospitals. In 1963, the Community Mental Health Centers Act was signed as a bill. What this bill said is that we're going to take people out of these mental health hospitals and treat them into community mental health centers and make it all outpatient care. Okay? Move forward a little bit. What does that leave us with? Well, there are about 40,000 people now in state hospitals throughout our country. And the rest, well, many, or maybe I should say some, are getting help in these community mental health centers. Not everyone. I'm afraid I can tell you where many are, as we talked about, in jails or homeless, and we'll get into that in a little bit. But let me talk a little bit about stigma and how it's really impacted so many fields, and some of this is going to surprise you how deep it was. As a doctor, every year, or every few years, I can't remember what it was, that I had to redo my medical license for the Colorado Board of Medical Examiners. There was a part in the questionnaire that asked you about your mental state, your mental illness. Do you have mental illness? Are you able to cope? And it turns out that a lot of my colleagues, not a lot, some of my colleagues were suffering from mental illness, great docs, but they were afraid to write down on the questionnaire, yes, I have a mental illness. And instead, they kind of got around it and said no, getting care almost in a type of black market atmosphere of being treated. I was, as the chief of family medicine at Kaiser, I had unique experiences. I had leaders in pediatrics, internal medicine, with fairly serious mental illness who would come up to me and go, hey, Jonathan, if you see that I'm acting out, if I'm doing something wrong, would you please tell me? I'll explain what the term is associated with that. Because they were so afraid, they were not even aware of some of their own behavior, of what living with mental illness meant and being a doctor. It was just very sad to see that. Here's one that'll get you. Did you know that before 2010, commercial pilots were not allowed to take medicines for depression, antidepressants? How many knew that? Okay. Think about it. You're going on a plane, and would you like your pilot treated for depression or untreated for depression? To me, it was like, what are we thinking in this world? Now, it just really surprised me that it came down to that level. After 2010, they've opened it up, so it's much better, much easier to get treatment for depression now as a pilot. But again, stigma is you're enveloped with it. Health insurance companies. Okay. Health insurance companies is an interesting enigma about they're called health insurance companies, and they're supposed to take care of everyone. But for mental health, there was a lot of roadblocks. We'll get into that a little later as well. One of them, it got so bad with mental health and creating parity between physical medicine that there was the Mental Health Parity and Addiction Act was passed in 2008. It didn't hold up, it wasn't enforced. They augmented it in 2014. Sort of, helped a little bit. In 2024, they added another bill to it, and now there's another bill to enforce it. The problem is enforcing the healthcare insurance companies to allow networks and reimbursements to be robust for mental health. And I'll talk a little bit about that later. I want to get back to stigma a little bit, but I think that's stigma as well. So as you can see, I'm talking about stigma at various levels of healthcare. In Japan, there was so much stigma associated with the term schizophrenia, they renamed it, called integration disorder. Okay, that's fine. And people had more, it felt more comfortable getting care for schizophrenia. In Korea, they also changed it to, and this one I'm still getting my arms around, attunement disorder. And that's fine, but they wanted to open up the doors and take away the stigma associated with schizophrenia. Serious mental illness. Let's see, let me see if I can do this right. Oh, I want to do this one slide. This one's actually quite good. Can everyone see that, or you want me to read it to you? Okay. He seems to be depressed. Let's label him and see if several years of unemployment, hopelessness, and poor relationships helps his condition. Okay. Serious mental illness, one of the topics that Betty and I are going to be talking about. It includes things like schizophrenia, schizoaffective disorder, bipolar disorders 1 and 2, which are characterized by episodes of mania or severe depression. And that's how they differ in bipolar 1 or 2. I'm not going to quiz you on that one at the end. It's also obsessive compulsive disorder. There are a number of docs in my own group had OCD. That was quite clear. Panic disorder, PTSD, and bipolar disorder. Bipolar disorder is something, I'm not going to go into it at any length at this point, but that is more common than we think. And it's also something that they're trying to change the name to really signify what it represents, which is emotional dysregulation. The term serious mental illness actually was first developed in 1992. And what it was is that they decided it was a serious mental illness that impacts daily living activities. Actually, it's more based on the ability to maintain relationships, be able to work and maintain a work environment. The employment, the relationships, personal and family, it began to be noted, 8 and 26, 30, let's say 35 years ago. This was making a significant impact, huge impact. But they didn't catch it fast enough, and we know that serious mental illness led to homelessness, incarceration, or long-term hospitalization, because there wasn't a lot of care that was being delivered at that point. There was not a lot of prevention. We weren't thinking about how to help this and catch this disease, these illnesses early. Betty and I have been attending the Santa Fe County Adult Detention Center, and they have a very unique program. I'm not asking you to go to the Adult Detention Center to find out for yourself, and we were guests. We were not, we were able to go freely after that. But they have a program called Matrix, because what they noticed is that a lot of the inmates were coming out of being incarcerated, and they were being released to the community. Believe it or not, they're being released. They opened the doors and they had to walk from the Santa Fe County Detention Center back into town, which is many miles away, or get a bus. But it was very strange, very strange. What this program did was fascinating. What they did is they gave them huge amounts of psychological counseling and helped them with their mental illness, which a significant amount had anxiety, depression, and the big one was what they called, and they labeled it, anger management. Then what happens when they're released? In order to decrease recidivism, going back to the jail, they put them into systems like with LifeLink and systems like that hook them up with a whole counseling system to keep their eye on what the inmates are doing so they know they're going to get the care. What we found out when Betty and I talked to them is that I said to them, how important is it for you to continue your care when you get out of the jail? And they all said yes. We want care. We don't want to be isolated. We need this support. 45 to 65% of the inmates in federal, state, and local jails have been diagnosed or having symptoms of a serious mental illness. Serious mental illness, people think in their minds is that it's always given some medication. You've heard of schizophrenia being treated with certain medicines like Haldol you may have heard of and things like this. There's a lot of other medications. I'm not going to actually get into that. But I wanted to bring to your attention that serious mental illness is not always treated with pharmaceuticals. In fact, if you look at certain mental illnesses, especially borderline personality disorder and PTSD, these are treated with cognitive behavioral therapy. So what it does, it teaches individuals how to rethink how they're responding to negative thoughts with themselves, and how to rethink those relationships that they're interpreting in their own minds. So that was an important aspect to learn about that. ECT, electroconvulsive therapy, you've seen the horror shows of that one. It's actually quite well controlled these days, and it turns out to be extraordinarily effective for recalcitrant schizophrenia or bipolar 1 or 2. So it's no longer what you remember from the Dr. Kildare shows. I think I got that correct. But it's actually well controlled. There's minimal side effects to ECT today, although they do occur, but it's shown to be quite effective. The other ones are still requiring medications, and some of those medications have really significant side effects. 50 to 98% of those people with schizophrenia and 40% of people with bipolar disorder, they have something called anosognosia. Now, which was a term, Tyler, you're going to appreciate who came up with that term, Dr. Babinski. and he was a neurologist. Tyler and I, when we were training, we learned something called the Babinski sign, which taught us about stroke patients, I think, if I can remember correctly. So what is this? What does this term mean? The term means that they think that their hallucinations, auditory, visual hallucinations, or their thought patterns are normal. Isn't everyone experiencing this? This is normal. Has anyone heard of Dr. Xavier Amador? Okay, Xavier Amador wrote a book, I think it was in the 80s. He was a PhD student at Columbia in psychology. Going to get his doctorate in psychology at Columbia. But Xavier had a brother with schizophrenia. And in those days, treatment was, fairly high doses of Haldol, and there weren't a lot of options, like talking to your patient. And what he did is actually spent a lot of time, because he truly loved his brother. Oh, I'm sorry, am I going way over? Okay, I'm sorry. And he found out how to create goals, how to create care models for patients with schizophrenia, which really helped. But if you can see the term anosognosia and side effects, we have poor compliance. I'll try to speed up a little bit. 6% of the U.S. adults live with a serious mental illness. 30% of those receive absolutely no treatment. 60 million adults live with a mental illness in the U.S., and 50% receive no treatment. Half of teens ages 13 to 18 today are thought to experience a mental health illness, mostly with depression and anxiety, while 20% have already been diagnosed with a mental illness. This will make you happy because I think there are a lot of gray-haired folks here. 1 in 4 folks with Medicare live with mental illness, but only about 40 to 50% get treatment. Access to care, significant workforce shortages, and affordable care are also barriers. Now, one take-home point, I'm almost done, Tyler, I apologize. 40 to 50% of all mental health care providers take absolutely no types of insurance. So you only get the care if you can afford it. Think about it. 40% of the people in New Mexico are on Medicaid. So as you can see, many people are living with mental illness, not getting the care they need, and many people are feeling alone and hopeless. In helping and supporting loved ones, this is what NAMI does. This is one of our goals. And we're going to try to change a lot of the approach of what mental illness is. Thank you. I'm going to be introducing Betty Shover, who's the executive director, and I apologize for going over. Betty is the executive director for NAMI Santa Fe.
Thank you, Jonathan. I knew he'd go over. It's Jonathan. I just want to add one statistic. I tried to get him to add this one statistic. 414,000 adults in New Mexico have a mental health condition. That's more than 4 times the population of Santa Fe, just to put it in perspective. So full disclosure, I'm not a mental health professional. I'm a person with a lived experience, having cared for my son for over 20 years now, whose diagnosis is bipolar disorder. But I have been with NAMI for over 20 years. I have learned a lot, and not just through my lived experience, but through NAMI's programs. And the reason I've sort of dedicated myself to mental health advocacy is because of what I experienced when I first became involved in NAMI, went through a family support group, and then went through a family-to-family education program. And I was just so taken with how much it helped my family. My late husband was an engineer, and you know, engineers are very analytical, and if A, then B, and mental illness doesn't work that way. And so when this program helped him, it helped me, helped our marriage, it helped our family. And I see it every time I do a family-to-family program, every time I facilitate a support group. So my next slide is, I can see that. Okay. What contributes to serious mental illness? I'm going to talk about genetics, brain chemistry, stressful events, and trauma, in just saying that we know that research tells us that mental illness has a very high heritability rate, ranging from 30% to over 90%, with conditions like schizophrenia, 73 to 90%, bipolar disorder, 60 to 85%. But I want to say that the key takeaways from this chart, for at least the first 4 items on this chart, is that there's no single gene. No mental illness is 100% genetic. They result from complex interactions between multiple genes and, of course, environmental factors. Then we have epigenetics and trauma. Experiences such as trauma can activate or deactivate genes, influencing the risk of developing conditions like depression and other serious mental illness. And also, these high heritability diseases like schizophrenia and bipolar are often influenced by non-genetic environmental factors as well. So those are key takeaways from the first 4 items. The other items, which are no less important, are abusing drugs and alcohol. Because we know that these can interfere with the way brain cells work and function, and they lead to neurological and behavioral conditions, both immediate and long-term. We see that from some of the, we have these every second Tuesday of the month. NAMI holds a public information talk series, and you're always welcome. Go to our website and look and see when our next talk is actually this Tuesday. But we've had people like from the New Mexico Behavioral Health Institute, our state hospital, come and talk to us. And one of the most recent talks was about how people coming into the hospital, it's just difficult for diagnosis anymore when you have alcohol and substances affecting, I should say, evaluating whether it's just a substance abuse and alcohol problem or is a real mental illness, because the symptoms are so similar. And with the fentanyl that's out there and meth, just becomes very difficult to decide for mental health evaluators what came first. The other issue is noncompliance with medication. Let me just say about alcohol and substance use. We also see a lot of co-occurring disorders, mental health and substance use, because individuals will self-medicate. I'm sure some of you who have experience with mental illness will see that. Noncompliance with medication also contributes to serious mental illness, often driven by poor insight. Jonathan talked about anosognosia, the inability to really understand that you have a mental illness. That contributes to mental health decline, sometimes leading to severe symptom exacerbation, and then higher rates of suicide and reduced quality of life. Okay. Can't really read that. Diagnosis, okay. I'm going to try to go quickly too. So diagnosis and recovery. There's no physical test. We all know that. So as many of you know that diagnoses are generally done by clinical observation and taking a person's history. Treatment is key. Up to 65% of people experience partial to full recovery with appropriate treatment. However, I think Jonathan said about only 52% of adults actually receive treatment in New Mexico in 2024. So we're not there yet. Of course, we have our issues with behavioral health access to care in New Mexico, as well as other places in the country. Treatment. We know that our best practice in treatment is both medication and therapy. And then, of course, we always know that there's just a constant reevaluation, because as many of you know, people with mental illness go through years of trying to find the right medication. They have to be reevaluated, they change medications. My son has been on, I don't know, he said the other day, I don't know how many medications I've been on. Some of them have not been good outcomes. And you kind of hold on waiting and hoping that it is going to be a good outcome, and then you start seeing that, okay, this is not going the right way. And just for people to understand, recovery, you know, we talk about recovery with substance use. Recovery for mental illness is different. It's not synonymous with being cured. It's just a process of learning how to minimize your symptoms and to stay well, recognizing your triggers and trying to live a good life. These are kind of my cornerstones of recovery: self-determination, treatment, engagement with family and friends, work, hope, and NAMI and other support. And I just want to really focus on engagement with family and friends, because that's really my thing. It's so important to engage with family and friends. We know that research actually shows that that people with mental illness who have their families involved have a higher rate of recovery. It helps with just being involved with family and friends, helps with treatment compliance, helps with recognizing early warning signs so that you can keep that person from going to the hospital again. It reduces isolation and stigma. It's also a certain amount of emotional and physical safety. Social supports, for one, boosts oxytocin, lowers cortisol, and provides somebody that sense of belonging, which is critical to managing mental illness. And just practical assistance, people who have mental illness many times need help making appointments, getting to the doctor, remembering those appointments. Let's see, where am I? Okay, let's go to chart 10. I want to talk about how NAMI makes a difference. We provide, all of our programs are free, so we provide both education and support programs. They're peer-led, which is NAMI's model, as peer engagement is their model of support. Most of us have lived experience, and that's how we help others. And then it's supported by evidence-based programs that NAMI teaches us to provide to our community. And then we also advocate, like Jonathan and somebody was saying. I go to the, I advocate by going to the legislature every time it's in session and testifying on behalf of bills or nixing bills that sometimes don't meet our criteria. So that's another way Jonathan's on the Behavioral Health Leadership Council. That's another way we advocate, and we advocate for our own family members. Let's see. I think Jonathan talked a lot about stigma and diffusing misconceptions, but I just want to say that one of the ways NAMI helps with stigma is we're very open in our discussions in public, in our own meetings about mental health. Many of our members are people with mental illness. In fact, we have a program called Connection Recovery Support, which is for people with mental illness, helping others. And the two facilitators we have, actually one is was a scientist from here in Los Alamos, and the other one is a retired attorney. So it just kind of shows you that people with mental illness can recover and can lead a good life and can help others. Our education programs are life-changing. I can't tell you how much that changed. It used to be a 12-week program. It's now an 8-week program. We're also very conscious of the language we use, and we call out people who don't use the right language. A lot of people say, oh, he's bipolar, he's schizophrenic. We like to say he is challenged with bipolar or he is suffering from schizophrenia, because we try to see the person first and not the illness. We encourage equality between physical and mental health, because we know that these diseases are biological brain disorders. And we try to show compassion at all times for people, both families and individuals. And when we catch people in the media saying things, we usually try to come out and say, you got it wrong. We especially get this around Halloween when people put up, psycho rooms and that kind of thing. And NAMI will take a big stand on that. I'm not going to go in too much the 988 Lifeline, but have you guys all heard of 988? Who has heard of 988? Okay, good. So their promotion is working. So 988 is what used to be the suicide prevention helpline, I believe. It's now used for mental health crisis, for suicide, for really anything, and you can call anytime and talk to a trained counselor about anything. If they believe that you need help, then they will call someone in an emergency or a crisis line for you. So just be aware that 988 is there. I'm not going to go through all the programs, but just so you know, we have several education programs, also several support group programs. We have a family-to-family education, which is like many of us that's how we've gotten involved in NAMI. The peer-to-peer education program is for people with mental illness. It's another 8-week session. And we have been trying to start a basics education, which is an education program for parents of children. You know, it's a little hard in Santa Fe because it's an older population, but we're plugging away trying to get people involved in that. And then these public information talks, which we're very proud of our public information talks because we bring in speakers from all over. What's the last one we had? Trying to remember the last speak. We've had speakers on mental health parity, on how to get your insurance to pay, because we still have issues with parity. We're having Reverend Talitha Arnold speak this week about how faith communities help with mental health. So if anybody was interested in that, you can just go to our website and sign up for those. And again, to learn more about NAMI Santa Fe, and I've got some brochures in the back. You're welcome to take some on the way out, and it has all of our information, our website, our telephone number, how to email us, and about our public information talks. Our memberships, we really don't push. They're only $40 a year. We send you everything anyway if you're a member or you're not. Once you're on our mailing list, we have you. So we sustain ourselves through donations, and we're very, people are really generous. I've been very proud of the fact that our community supports us. We are having our NAMI walks on May 9th at Alto Park in Santa Fe. So if anybody wants to come down the hill and join us at the walk, we will be having that at 9 o'clock in the morning. Our mayor will be reading a proclamation as May is Mental Health Month. We'll have Director of Behavioral Health Services Division, Nick Bucas, who's at the state level, and we'll have Representative Tara Lujan speaking. So those are 3 dignitaries that will be speaking, and we'll also have one of our own board members, new board member to us, who will talk about, do a testimonial on how NAMI has helped her. So anyway, there's also a card back there on our NAMI walk, so if you want to pick that up and join us, hopefully it'll be a nice weather day. And now we welcome your questions. We have one in the back.
Okay, now we're on. Okay. All right, questions and comments. Thank you guys so much. That was great. You have to hold it pretty close.
Okay. Thank you. This was very helpful and informative. We appreciate you all coming up here. My question is for Dr. Gordon, I think specifically. Do you notice any connection between people, and perhaps mainly youth, who are diagnosed with neurodivergence that are on the spectrum and with serious mental illnesses? Is there any relationship or connection? And if so, could you explain a little bit?
Yeah,
What I want to say about that, because I was just actually looking up a neurodivergence or autism spectrum, right? So our programs don't touch a lot on autism spectrum, but we realize that many people with that neurological disorder also have mental health issues. And so we help in that regard on the mental health side. Does that answer your question?
I appreciate that. Thanks. I was kind of looking for like the clinical perspective.
This is not my area of expertise, so I probably best for me not to venture into that area. I think there's it's autism is still
More neurological?
well, yes. I mean, there's many causal issues associated with autism and understanding autism, and I think we're still learning. We're learning so much about autism, which is a very slow process, I'm afraid.
You said that you advocate at the legislature. I would like to know if there are ways that as citizens of New Mexico we can advocate at the legislature, because I am furious at how long it took them to pass the interstate compacts for social workers and counselors, and what they did to the doctors in our state, because we have such a shortage of psychiatrists. So I wondered if you had any suggestions of what we can do to advocate for them to get with it related to our mental health system.
You know, the roundhouse is the people's house, right? They always say, and you're actually all welcome to just come to all of the different meetings. You can even attend now by Zoom, which has been really helpful for a lot of our people in the southern part of the state or even Albuquerque to attend, and you can comment via Zoom. You know, we used to have a really good advocate for behavioral health, Senator Mary Kay Papin, who retired recently, maybe a year or two ago. And there's a couple of people that have kind of moved up sort of in her position, but we don't have really a good, for NAMI at least, a good person that we could always go to and say, you know, this is what we need to do. But I was happy to see that some of those interstate compact licensure agreements were passed. They ran out of time is what happened this year, and a lot of them were not. But it did take a long time. Well, and it took a long time for the medical malpractice reform also. But just show up or talk to your representative in your area and really push them. That's another way, is to really get to know your representative. Is it Representative Chandler here in Los Alamos? Yeah, I'd push there.
Do all of you know about Senate Bill 3? So Senate Bill 3 is a very, very multi-million-dollar comprehensive funding program for a comprehensive mental health care system devoted to the state of New Mexico. And it's going to be divided into the 13 regions, are basically based on judicial districts. So Los Alamos and Rio Arriba and Santa Fe are in judicial district number 1. So even though it's administered on a statewide level, it's the local community services divisions that are actually coming up and addressing the gaps, the workforce shortages, the resources, and trying to figure out how to do it. So there's good intention to try to fix this problem. I personally think it's a very complicated system. The Santa Fe County and Judicial District number 1 is faced also with 13 or 11 sovereign nations, and that's very hard, uniting all the tribal nations together and try to figure out how to deliver that comprehensive system. So, but they're going to take this seriously about a statewide approach to mental health care.
You can also join our NAMI Advocacy Committee and help us out.
This may be a more specific question than what you had in mind, but when you're being compassionate and trying to help family members, how do you distinguish between what's reasonable help and when you're being manipulated?
You know, I struggle with this all the time because I always think of my son and I think, would that just be his personality anyway if he didn't have a mental illness? You know, like maybe the manipulation or the narcissism, or is this really part of his mental illness? It's hard to decide what that is. But you know, a counselor once told me, in terms of helping versus enabling, is that I should allow him to do what he can do, and not, you know, not try to do it for him. So let him do what he can do, and just walk away from. Yeah, but I hear your question. It's difficult.
The question I have is sort of amorphous, but we're all very aware these days of the shortage of physical medical health care. We're aware of what feels like an even greater shortage of mental health care. Do you have data on how New Mexico compares to the rest of the nation? And I'm thinking, you know, psychiatrists, other mental health providers. Are we really worse off than the rest of the nation, like it feels like we are, or not?
The answer is we're equally worse off. And it's really a tragic story about mental health care providers throughout the United States. New Mexico is especially worse off, I'm afraid. So with psychiatrists, psychologists, MSWs, nurse practitioners, we're really going to be in trouble. And they have predicted by 2030 we're going to be in deep trouble of having not enough providers. You know, as a side note, I've talked to Dr. Taylor about this. My hope is to get this regional teaching hospital for mental health built in Santa Fe so we can have more mental health care providers, because the belief is if we train them here, they'll stay here and practice here. So hopefully we'll do that.
So NAMI has a rating scale from A to F on states, and New Mexico is rated an F. Just a lot of different factors, access to care and the availability of doctors, and yeah.
I'm going to call on my wife. Julia.
I just wanted to comment on your question. I think that we all struggle, family members certainly struggle with the idea of manipulation or enabling. And I think that comes from, there's a source of stigma in that thought. I think we need to be very careful about, and it is so frustrating. I mean, I think caring for people with mental illness is the work of the soul. And I'm not saying religious, I'm just talking, it's much deeper than that. And, but it's more complex than just manipulation and enabling. And there are times, I have both a sister and a daughter, and there are times, and I guess I should say this is a personal thought, and it's part of my training, is there are times when we talk more about limit setting versus boundaries, because limits allow you to change from moment to moment. And there are times when what we do for people with mental health issues, is not understood by many others. They see it as you're enabling, or you're, you know, or the person with mental illness is manipulating. I think it's deeper than that. I think it's more complex than that. So I don't know. I think while we're on this journey, we learn when we do more than others would do. And it's very nuanced and very personal. And again, that's where people who understand mental illness can be of great support. Even those with mental illness can help us understand that most of all.
Thank you.
I want to add to that. I remember when my kids were teenagers, and you know, just reading everything about how to raise teenagers. And I remember reading about tough love, And people still say, just let him, he'll figure it out, just let him go, and it doesn't work. Tough love doesn't work with mental illness, and mental illness is not logical. And as one time my son decided to drive from Denver to LA in his car with no gas and no money, and my sister said, "That's not logical at all. Why would anybody do that?" Well, mental illness is not logical.
So a follow-up question I want to ask is, if we have an F rating, is there a way that the legislature of the state is getting the message that, this is a real problem nationwide, but we are really at the bottom of the barrel here? Is there a way for them to really encourage a lot more mental health providers to come into our state?
Well, I think part of that is SB 3, this new legislation that allocated how many billions of dollars?
Well, it's a couple of billion. It's billions, but it's a different way of how they're going to be spending the money. Again, Tyler, they're well aware of these gaps. The gaps are huge in New Mexico, and workforce shortages is major, and they understand that. For example, the psychiatry department at UNM, who actually supports building this hospital, and they want to staff it, which is fundamentally great. The problem is the total residents, those doctors in training to be psychiatrists, is 13. That won't cut it. It just really won't cut it. So how do we decrease the obstacles, the barriers to getting more people in mental health care? How do we make sure that the reimbursement rates for providers is fair and equal? And so there are a lot of challenges, and I think SB 3, Tyler, is trying to attempt to figure out those gaps and address those to make it a comprehensive system based on the 13 judicial or regional districts in New Mexico. So your question is spot on. They're going to try to figure that out.
And I think the other challenge we have in New Mexico is we're a very rural state. So trying to provide providers in a very rural state is a big challenge.
The one thing that kind of interests me about the F rating, I was actually a little surprised when you said that. Not because I don't think that there's enough providers or anything, but when I talk to people in other states who deal with mental illness, what I found is that regardless of their lack of providers, a lot of the things in the state put in place to support people with mental illness are really lacking. Whereas at least New Mexico, if you're on Medicaid, they don't require that the only places you can go to seek therapy is their mental health co-ops. And I've talked to a number of people in other states where, everyone with mental illness has to go to these mental health co-ops, and they can't find therapists who suit them. Whereas I have a therapist who takes Medicaid, and she purposefully got on the Medicaid so that she can see people. And it would be terrible if I could only go one place and go to the assigned therapist to them. And so I guess I was a little surprised but I do want to point out that although we don't have enough providers, and there are a lot of ways in which we're failing, there are a lot of ways where, at least in New Mexico, we're trying to help people and trying to reduce stigma.
We are, and our state has been really good about providing Medicaid. Again, the problem is it's lack of providers, and yes, we have ability. You don't have to have pre-authorization to go to, and you can choose whatever provider as long as they take Medicaid. But it's the wait times a lot of times. It's, to get for an intake evaluation can take over a month. By that time, somebody's decompensated and they ended up in the hospital, and they're in that cycle of hospitalization and rehospitalization until they can get into a provider that, that's stable, and that person can become stable and get on the right medication, which, like I said, oftentimes takes years. I think that's the problem, is that we don't have enough, and then the people we have are just stretched.
Hi.
Yeah.
Hello. Thank you so much for coming up the hill to educate us about NAMI. I saw it in the paper last week, and I went through your website. It's really well, I would say, organized, and there's so much information there about other resources in Santa Fe. So I really appreciate that. My question to you is, it seems like you don't have any medical staff or mental health staff on in these peer groups or in these family-to-family groups. And you're saying that you're establishing or trying to establish this clinic, this research clinic or school. Who are your medical partners that you're working with in Santa Fe or in New Mexico? Who are your biggest supporters that will actually make this happen?
I'm going to let Jonathan answer the regional mental health hospital issue, but we don't have medical partners because that's the way NAMI wants us to be. NAMI is a peer engagement model. It uses our lived experience, either as family members or as individuals, to pay it forward. And so, in fact, even our programs where we're teaching anatomy of the brain, NAMI doesn't want us to have a medical professional teaching that because they feel like, we as having lived experience, that's the credentials we have. It's a person-to-person kind of thing, peer-to-peer. And I'll let Jonathan talk about the hospital.
Yeah, it's a very fine line about providing care itself, or mental health care or physical health care. And so we don't do that at NAMI at all. I didn't do it for Mental Health Colorado. And so we had to be very careful of how we advocated, because it was through our lived experiences with our families, or what we did with our lives, especially my work life. In terms of providers, to support the concept of an interdisciplinary teaching hospital for mental health, dedicated to mental health in Santa Fe, University of New Mexico completely buys into this, and they want to be a part of this. They want to help solve the problem. So that was a big player to get them on board.
But this is not a NAMI.
This is not a NAMI initiative. I have to be very clear. I wear a few hats.
We support it.
Thank you.
We support it.
It's not exactly NAMI, but it's, it all blends together eventually. But
part of our advocacy as NAMI to support something like this, just like we would support AA, or we would support other, clinics that provide treatment.
We're over an hour here now. This has been a wonderful presentation, wonderful questions, comments. Thanks so much, everyone. Let's wrap it up and give them a nice round of applause.
Thank you.
Thank you.
Thank you for having us.